Thank you very much, Axel. Ladies and gentlemen, some of my slides will be similar than the previous one, but the goal is to go, as Axel said, a little bit more in depth and to take them more as a, let's say, as a basis for further discussion in this situation. The guidelines, and that's, you have NCCN, I come from Europe, so I often show ESMO guidelines, but there are a lot of similarities in this. And what we're discussing right now is the later lines. And the definition of what is later line is not easy. But here, for the sake of the symposium and the debate, I take into consideration patients being pre-treated with the different cytotoxics, fluoropyrimidines, oxaliplatin, irinotecan, with bevacizumab, and in the wild-type patients with an anti-EGFR targeted agents. And I've shown you already this slide just to highlight you some of the mechanisms of the different angiogenesis inhibitors. And in the continuum of care, as we call that, it's important to understand the data of the different clinical trials that are available, and we can go more in detail during the discussion on that also, but also to understand the mechanism of action here in later lines of Regorafenib, and I've shown this slide also looking at the different receptors with which Regorafenib as a multi-target tyrosine kinase inhibitor interferes. The design of the different trials, we were fast on that this morning, but let's go a little bit more in detail and especially highlight some of the aspects that are relevant for the discussion. That's the design of the CORRECT study that Axel and myself had the privilege to chair. The CORRECT study, there was a 2-to-1 randomization, pre-treated patients, and it was mandatory that they were pre-treated with all different agents that I just mentioned. So the 3 classes of cytotoxics, bevacizumab, and an anti-EGFR antibody. At these days, in KRAS wild-type patients. Today, we don't speak anymore of KRAS, we speak of RAS. We do a more extensive testing, as you know, but the trial was done before the time of KRAS. But looking at that, KRAS is not a predictive factor. We can discuss that later on, but it's not a predictive factor, neither for Regorafenib, neither for TAS-102. Although some subgroup analysis may show some trends towards, let's say, a bigger benefit in one of the different subgroups, but that's not the case. So the KRAS or RAS story, the trial is still applicable in this situation. That's the endpoints of the primary endpoint on the left side, secondary endpoint on the right side. You've seen that a benefit for as well survival as progression-free survival of Regorafenib. I didn't show this slide this morning. That gives us an idea on, and that's what all patients ask. Will my tumor reduce? You know already in the meantime that there are virtually no objective responses in patients. We see some minor responses, as is illustrated in this waterfall plot, placebo on the left side, Regorafenib on the right side. You see that a bit more patients have minor regressions. We see changes. I illustrated that, and I will show you again some of the slides because this is striking. And we have done now a radio-correct study, which is a detailed analysis looking at the cavitation of the lesions after Regorafenib treatment under leadership of Salvatore Siena from Italy. The data have been presented, but will be published hopefully in the near future. The CONCUR study is the other study. We went into detail in that this morning also. That's the other study. It's a much smaller study. It was a study in Asian patients. The main difference with the CONCUR study and the CORRECT study that we discuss most often is one, that it's much smaller. 2, that patients were not, that they didn't all receive bevacizumab or an anti-EGFR antibody. So they were less pretreated with targeted agents compared to the CORRECT study. And that's the endpoints, as I've shown already. The survival in CORRECT and CONCUR, very similar benefit, is maybe a bit bigger if we are allowed to to compare hazard ratios, a bit better hazard ratio in CONCUR. We don't know why this is. One hypothesis, and what for sure contributes to that is probably a little bit less heavy pretreatment with targeted agents, as I mentioned this morning. And that's again for your benchmark also the progression-free survival difference. Similar messages between CONCUR and CORRECT regarding the pretreatment here. And the third large study, and that was at the request of the authorities. Different authorities asked us to, or asked Bayer to do a bigger data set, another study, to see what is the safety pattern of Regorafenib in larger cohort of patients, and that's why 280,000 patients were included in this trial. Again, with under 60 milligrams starting dose. That's not what most of us do today, as was also with the vote this morning. And with the lower dose, we have a better safety profile than with this higher dose. But the good news is that with this higher dose, there was in clinical practice, wider clinical practice, with probably a little bit less stringent selection of patients. With the higher dose, there was a similar number of adverse events compared to the original stringent CORRECT study in this. Progression-free survival was 2.7 months. In the CORRECT, it was 1.9 months. I don't think we can say that in clinical practice this is longer. This is just reflected, as I mentioned also this morning, by the fact that the scans in some patients, not all patients, were done at 3 months. And if you don't do a scan, you don't detect progression in some patients. So that's the reason why this is a bit longer in this regard. Some other data, a frequently asked question is, do we have some data on markers, biomarkers, in view of the mechanism of action of the drug, and in view of what we need, and in view of the fact, if we see I didn't draw your attention too much on that, but if we see this type of curves of progression-free survival, and that you see, if you look at the top curve, for instance, that some patients stop the treatment, also in the yellow curve in the active arm, that means that there are some patients who go on, and that means that there is a subgroup of patients who benefit. Typically, if we see this type of curves, we are striving and we are willing to have a biomarker who can help us to detect and to predict which are the patients that do benefit. And that's one of the reasons, of course, why there was an extensive molecular marker analysis being done. And as I believe Axel mentioned this morning, a biomarker has not yet been found for Regorafenib. But there are some interesting data that were presented recently. And then I go back to what was discussed also this morning and what will be discussed tomorrow more by Josep Tabernero. That's the consensus molecular subtypes. In Nature Medicine, there was a publication on the 4 different subtypes, the CMS 1, 2, 3, 4, in colorectal cancer. This analysis was based on patients, non-metastatic patients. There is ongoing work now in patients with metastatic colorectal cancer also to see whether how that fits and how the different groups represent in this situation. But what is shown, and there's what is shown also in this CMS study is that the different subgroups have at least a prognostic value. We don't yet know whether there is a predictive value. Predictive means whether it can help us to predict for the efficacy of a treatment. And you've seen that, for instance, MSI is clustered in one of the groups. So maybe we know that MSI is a predictive marker for the checkpoint inhibitors. So there will be for sure implications in clinical practice also on that. And the CORRECT study, there was an analysis that has been presented looking at the different subtypes, and what was shown and suggested, I don't want to say shown, what was suggested is that patients with the CMS type 2 and CMS type 4, that in this 2 groups of patients, the so-called mesenchymal which is a CMS type 4, and the so-called epithelial, which is the CMS type 2, that in this subgroup of patients, as you can see, the hazard ratio, and it's highlighted in red, the hazard ratio for overall survival was a bit more favorable than in CMS 3 and 1, where there was no benefit. Can we use that for clinical practice? The short answer is no. We need to validate, more work has to be done, but at least it seems to be interesting in this, and I'm pretty sure that within the next couple of years, this CMS classification and this taxonomy of colon cancer will be, one, fine-tuned, and two, will have more practical applications in clinical practice within the next coming, let's say, 5 years for us. But it's interesting and at least appealing that also for Regorafenib, that we see trends in this retrospective analysis, trends for a better outcome in 2 of the subgroups, 2 of the CMS subgroups, while this is not the case in 2 other groups. So that's interesting new information that we have to follow in the future in this. Just to bring you back to I've shown you this image already. This is a typical image, what you see not in all patients, but what you see in some patients, this what we call this cavitation. This is also seen when you treat patients with bevacizumab, but you see it to a lesser extent in my experience in earlier lines. You see it a bit more with Regorafenib in this, and we saw it, and this was an observation, clinical observation. We saw it a bit more in patients when they were longer on treatment. And therefore, the idea came up to do an analysis, and that analysis is called the RadioCorrect study. That's the radiology of the correct images of the patients in the correct study, and that's an international collaboration. It's an academic study led by, as I mentioned, Salvatore Siena from Milan. This is another example of a patient. I've shown you the images already. And in this study, in this RadioCorrect study, and I thought I had a couple of slides on that further analysis, but what was shown clearly is that patients with cavitation, there was a longer progression-free survival, a longer outcome in this group of patients. In other words, you don't see the metastases. If you measure them according to RECIST criteria, you don't see them shrinking. But you see in some patients a cavitation. So if you see a cavitation, and I'm quite convinced of the data, looking from our own patients, we did an analysis in Leuven of correct and also Consign patients, but also then looking from the multi-center collaboration in this study, it is clear that if you see cavitation on the first at 2 months, for instance, that you see a benefit and a longer benefit in some patients. And that's a challenge. It's not always easy to measure, because if you would do, maybe that's not the best example, but if you would do the measurements of the metastasis, according to RECIST criteria, it's extremely difficult to say, for instance, in these patients, whether what is the measurement of metastasis like that, how you have to do that in clinical practice. That's extremely difficult in some of the patients, but that's clinical reality. Here, for instance, you see at baseline, and you see a couple months later, if you look at this lesion with RECIST criteria, you would see no clear benefit, of course, in this patient. But sometimes you see, if you would do that in RECIST measurements, and I don't know really how we have to do that, you see sometimes that this outer rim becomes even a bit larger in this with the central cavitation, and that's extremely difficult to measure. So we have to learn clearly more on that in the future for that. TAS-102 is another option. We discussed that this morning, Axel and myself. We didn't, that's the mechanism of action. We didn't go into detail into that. TAS-102 is a combination of different chemical substances, FTD and TPI, which have both a contribution, and it's it's a fixed combination of FTD plus TPI. TPI is tipiracil and FTD is trifluridine. And it has a different mechanism of action of 5-FU. It's not just a 5-FU. 5-FU inhibits, through inhibition of thymidylate synthase, DNA duplication, while TAS102 is incorporated into DNA and leads to DNA damage. And also here, this drug has activity. According to the Recourse data, we discussed that. Axel mentioned, I don't know whether you paid attention to that, that we are not sure, that he is not sure about the dose, and I can agree on what he said, and especially for further development. TAS is a fluoropyrimidine. It's logic that that will be combined with oxaliplatin, with irinotecan, but the schedule of TAS is 5 days on, 2 days off, 5 days on, 2 days off, and then 2 weeks no treatment. That's extremely difficult to combine with a cytotoxic like oxaliplatin that you have to give every 2 weeks or every 3 weeks. So the scheduling is extremely difficult. So there is ongoing work, and Josep Tabernero and others are doing phase 1 studies right now to look at different schedules. They want to 5 in week 1 and they want to 5 in week 3 to make it more combinable. Because otherwise you will have too deep neutropenia. Our Japanese colleagues have presented a study also in combination of TAS102 with CPT11 irinotecan and have come into this issue of really deep neutropenia and neutropenic infections in combination. So there are clearly some differences, and there is clearly more work to be done also with this drug in this regard. The data and the design, for the sake of time, let's keep more time for debate. I've shown that already. This is also, I've stressed that, and this came back in the debate also this morning. In the TAS102 study, 20% of patients, as you can see here, the distribution were pre-treated with regorafenib. The hazard ratio in both groups was exactly 0.69. Whether they were pre-treated or not pre-treated with regorafenib. And a criticism that is often given, and that is, well, these drugs in later line of treatment, the benefit is so minimal. Should we really go for these drugs in later lines of treatment in this? And that's the reason why here you see the hazard ratio, and sorry for the white letters, but you see the hazard ratios of the different studies. These are the 2 studies with regorafenib, Correct and CONCUR. This is a study with TAS102. You see the hazard ratio. In this third line or later line studies is between 0.55 and 0.77. These are studies in earlier lines where you see hazard ratios. So the relative benefit, and I know the setting is different, the relative benefit compares favorable, and I acknowledge that we have to be careful with stressing that too much. But there is a benefit in this, in these different studies that is undoubtedly there. Selection of patients is, of course, crucial in this setting, and that are some of, let's say, the starters for the discussion, and we can discuss furthermore in detail some of these statements.